ആകില്ല. ഒരു മിനിറ്റ് കൊണ്ട് ചൂടായി. Purva, shall I start?
Yes, sir, we can start.
Thank you, Purva. Good evening to all of you. Can you see my slides? Hello? Can you see my slides?
Yes, sir.
Yes, sir.
Yeah. Okay. As usual, I will start with a short case first. I'm sorry that I got a little sore throat, so my voice is a bit husky. Anyway, we'll try our maximum. This is a story of an 88-year-old diabetic. This patient was previously admitted in this hospital 2 weeks back with 1 week history of pain in the right arm, followed by weakness of the right upper limb. At that time, patient had weakness of right deltoid, biceps, brachialis, and external rotator with absent biceps reflex. He was put on treatment with minimal improvement. Presently, he was admitted with worsening of the right upper limb weakness. Along with that, he also noticed difficulty in walking with tendency to fall backwards. No pain in the right lower limb. No sensory complaints other than the pain. So this is a short story. He was initially admitted with right upper limb brachial weakness, which remained static, then worsened again. With the worsening, he also noticed weakness of the right. This is a video of the patient. Muscles were normal. Shoulder, shrugging shoulder normal. Left deltoid was normal. Right deltoid was only grade 2. Left biceps normal. Right biceps is about grade 3. Brachial is normal on the left side, weak on the right side. Biceps normal on the left side, weak on the right side, and normal on the right side. Internal rotation normal. Our external rotation was weak on the right side. Come to the distal muscles. Resistance is normal. So also finger extension is normal. Hand grip was normal bilaterally. And long finger grip, all small muscles were also normal. Now come to the lower limb. Tone was normal. Okay. If you might hypertone on the right side. Hip thrust is mildly weak, not very sure. Mildly weak. Hip thrust is normal. Left extension was knee extension normal. Right was weak on the right side. 4 to 4 plus power. That is weak. Dorsiflexion was normal bilaterally.
ശരി, കാല് ചേർത്ത് വെച്ച്
Hip
ചേർത്ത്
adduction,
വെക്കണം.
abduction normal.
മതി. ഇനി അധികം സമ്മതിക്കരുത്. ആ, കട്ടിലോട്ട്
Hip
തള്ളു.
extension also normal.
കീഴോട്ട്. ആ, ഇനി ചവിട്ടില്ലേ?
Plantar flexion normal.
ചവിട്ടിക്ക്. ആ, ഇനി ഇത് മുകളിലോട്ട് എടുക്കുക. പാദം മുകളിലോട്ട് എടുക്കുക.
Dorsiflexion also normal bilaterally. Flexus right biceps is less compared to the left side. Right is less, left is well elicited. Supine also more better elicited on the right, left than the right. So natural right biceps supine decreased, triceps normal. Knee jack, right knee jack, left is well elicited, right knee jack is absent. Both angle jacks are absent. Sorry, well elicited. Normally elicited.
മതി. ഇതും ഇതും ഒരേപോലെ കുറവാണ്.
He said pain is more on the right arm. As suspected, it's not decreased.
പറഞ്ഞു മതി. നല്ല വ്യത്യാസത്തിന് മാത്രമേ.
They're all normal in the arm, and it was normal.
ഒരേപോലെ.
It's equal.
ഇതേത് ഒരേപോലെ അല്ലേ?
No impaired sensation.
വൈബ്രേഷൻ അറിയാം.
Vibration normal.
ഉണ്ടോ? ഇപ്പോൾ
This is how you walked. Okay. On examination, kindness all normal. Motor upper limbs tone normal. Power right upper limb. Weakness and wasting of right deltoid. Biceps brachioradialis and external rotators. Other muscles normal. Lower limb tone normal. Power weakness of right quadriceps. Mild weakness of right hip flexion. Other muscles normal. Detail upper limbs. Biceps supinated. Decrease on the right upper limb compared to the left. Triceps normal on both upper limb. Finger flexion absent bilaterally. Lower limb knee jack. Right knee jack is absent. Left is well elicitable. Angle jack normal. Plantar indefinite. Sensation all normal. He said the increased pain on the right arm, or is it decreased pain on the left arm? We do not know. There is some difference he was telling. All other areas normal. Rhombus was negative. Box with a cautious gait. So where is the localization in this patient? Right upper limb and right lower limb. Is it difficult?
Right to C5, C6 radiculomyopathy.
Right, radiculomyopathy. But was there a myelopathy in this patient?
Right knee jerk is brisk.
No, right knee jerk is absent. Other way around.
Yes.
You got that's why. Left was well.
Plantar.
Sir, the patient is having weakness and wasting, sir. Within 3 weeks, he developed wasting also.
Wasting of the right arm, not of
Yes,
the
sir.
right side.
So possibly an element only we are dealing about, sir.
Right.
So possibly right brachial upper trunk flexopathy along with that lumbar flexopathy.
Okay, it's a good thought. You could sequentially. Okay, that's what.
How was the plantar, sir?
Plantar was indefinite.
Abdominal.
Abdominal flex, I do not know. I did not. It was normal.
I thought he has a mild spasticity on the right side on walking.
On walking, I think I'll show the walking.
Is his plantar flexion normal, sir? It looks as if he
Normal.
is,
No, I'll show the gait also. Just
വ്യത്യാസത്തിന് മാത്രമേ.
he's walking cautiously, but not dragging. Probably he has got hip flexion weakness now. Probably that may be giving him some difficulty in walking.
He's
Plantar
not lifting his heels. His right heel is not.
once again, I will see that.
ഉണ്ടോ ഇപ്പോൾ
Yeah, there is some such as you said, it's correctly. But plantar flexion was normal. I did not show you. He could stand on heel and toes without any problem.
Sir, on eliciting biceps jerk, was there finger flexion, sir?
Yeah, the right biceps and supinator decreased compared to the left side. Okay.
Sir, why can't it be right C5, C6 radiculopathy and right L2, L3 radiculopathy?
Okay, that's also another possibility. There are two possibilities. One, as told before, right brachial plexopathy, lumbar plexopathy. Second possibility, right C5 radical versus right L3, L2, 3 radical. That's both are possible.
But the internal rotation is strong, sir, and the external rotation is weak.
Only external rotation is weak, internal rotation is normal. Okay. Now the point against radiculopathy is that he had any root pain, nor any sensory loss in any of the distribution. And so much of a weakness in that thing, he did not complaining of paresthesia, nor any sensory loss. That is slightly odd. Same with femoral neuron, L2-3 radiculopathy also. But that is not an absolute differentiating point. I agree with that. Okay, what investigation you want to do?
Nerve conduction study.
Okay, I will do the nerve conduction now. NCS was done with its normal limits.
Yes, NCS, can it give some clue? Because the weakness is in the proximal.
Yeah, we can do the musculocutaneous and axillary.
Maybe brachial plexus
Yeah,
study.
brachial plexus study. That was done, that is normal. Somewhere that they missed that record to copy it over here.
So there is normal motor conduction study in weak muscles with absent reflexes. So then wouldn't we be thinking of a proximal conduction block?
No, because you've got a point there. Any weak muscle, element weak muscle with the normal conduction should consider proximal conduction block. That part is correct. But that need not always be true. In the case of axonopathy also, see, if there is a mild weakness, not a severe weakness, you can have a normal CMAP amplitude, especially in deltoid and biceps. They're large muscles, no? So a partial weakness may have a spuriously normal CMAP amplitude. Time again we have seen. Similarly, in neurologic hypertrophy affecting the cortices, you get a normal CMAP.
Okay, sir.
So your point is well taken. You have to keep that possibility also. But in that case, FA should have been normal, or if other parameters should have been abnormal.
Here all the FA were normal, sir.
Normal, a perfectly normal context.
In the lower limb also, sir. Femoral.
Lower limb also.
Sir, was the NCS taken in the initial period, sir?
No, not in the initial period. When you readmitted, no, that time.
Sir, one doubt. We have seen that wasting of the deltoid little bit is there.
Yeah.
So if the normal deltoid, normal CMAP, but in this patient there is some wasting already set. So don't we accept some CMAP decrease or doesn't proportionately go with?
No, that is a very intelligent question. But unfortunately, even with the wasted muscle, with the weak muscle, you can have a normal CMAP amplitude. I'll tell you the reason. The normal CMAP you have taken is 5 microvolt by 5 millivolt. But we do not know the previous CMAP in that patient. because it's largely variable from individual to individual. So that way you cannot say it is decreased. Suppose if you are done in this particular period, done in NCS, say 2-3 months back, at that time CMAP was 20, now it is 5. You can call it as abnormal. But so they have taken 5 is a lower limit of normal. That's all. So
Okay.
if we have a normal CMAP amplitude.
Then we would think of an anterior horn cell disorder, sir, where you have wasting. But the CMAP amplitude is relatively present.
I'll tell you, see, to produce clinical weakness, more than 50% of the muscle buckler should have been lost. Only you get an even gate 4 plus by weakness. So you can have still wasting, half of the muscle should be wasted, can be wasted without any clinical weakness. And have a normal amplitude also. Okay, so it's essentially they're all clinical diagnosis corroborated by NC study. The NC study is not going to differentiate whether it's anterior horn cell, motor nerve, or muscle or this thing.
Sir, could it be like any restricted form of GBS or something? Sir?
Yeah, that's also another possibility. A focal form of GPS or focal form of CADP. See, even then nowadays some people call brachial neuritis and a focal form of CADP.
It can be brachial neuritis.
Yes, that's the first. That's the doctor also said the first possibility. That's ideal possibility in this patient, brachial neuritis. But it so happened that after 3 weeks, patient developed right femoral neuropathy also.
That can also occur with the brachial neuritis sometimes.
Yes, right. So the other investigations done, CSF protein 49. So diagnosis. Now I'll show a part of video which I purposely left out. This point I have told many times before in the class itself. That will clinch the diagnosis.
Opposite.
Opposite
External.
is not at SV. All of muscles are normal. It's a sequential neurologic emetra. His initial episode itself, he had left upper limb which were not noticed. Subsequently developed neurologic emetric with right lower limb. This only to show that always make it a point to examine the opposite upper limb. That gives important information to diagnose brachial neuritis, because he can say straight away rule out a unilateral disc prolapse and things like that. Sometimes, the pain comes radiating pain in brachial neuritis, and you find biceps reflex loss. You may erroneously diagnose FACC radiculopathy due to disc prolapse. They even complain of neck pain also brachial neuritis. In those situations, you examine the contralateral upper limb for external rotators, an isolated weakness. So I said suprascapular movement. That cannot occur with the radiculopathy. That tells you don't do anything so typical brachial neuritis. So to complicate matters, sometimes you find innocuous disc also seen many times disc also the cervical MRI. So if you find a pain in the arm and disc there, okay, then definitely you think it's a disc prolapse. Unfortunately, but if you examine this particular point, that can undoubtedly make you diagnose of neurologic emetra. Any questions?
Sir, why NCS was normal, sir?
NCS was normal. Why it is normal? No, that's already told now. A significant weakness should be there to produce loss of CMAP. See, in hand muscles, decrease CMAP is easy to get. The proximal muscles with significant weakness also you can have preserved CMAP because the muscle bulk is large. That is, you got a normal CMAP in cortices most of the time. Okay. Shall I go to the next case? It's a long case. It's a good case. It's a 61-year-old male. His complaint started as paresthesia of the left hand below wrist for the last 2 months. There was no weakness associated with the numbness. But 1 month later, he noticed paresthesia both feet below ankle with inability to feel the chappal in the feet and loosening of the chappals while walking. 2 weeks back, he noticed aching pain and cramps of both lower limbs below knee, which was more while walking. The story started 2 months back as numbness of the left hand. He said, maybe the dose of, I don't know, he said dose, that's what he said. There was no weakness also with the numbness in the hand. 1 month later, he noticed paresthesia of the both feet, below ankle, with inability to feel the chappal in the feet and loosening of the chappals while walking. 2 weeks back, he noticed aching pain and cramps of both lower limb below knee, which was more while walking. Okay, this examination finding. Cranials are all normal. There is no obvious wasting of any muscles could be seen. Tone was also normal. Deltoid normal power. Biceps normal power. Triceps normal. And it was normal. Examine the small muscles of hand detail. They are all normal. Introshaven normal. Umbilicals normal. Opponents was also normal. Then palmar side negative. Palmar introshaven normal. Lower limb tone appears slightly hypotonic or normal tone. Hip flexion appeared normal on both sides. Knee extension was normal. Abduction appeared normal. Adduction normal. Mild weakness of the hip extension. I could just left knee could not overcome. Those were also normal. Almost normal. EHL was weak. Plantar function, I'm not sure. Slightly. Still, you could press my hand downward. Upper limb reflexes normally elicited. Triceps was absent, or just elicited on the left side. I could not get other times. Only one time there was a flicker. Finger brush was absent. Up-down reflex were absent. Right knee jack was elicited once, only one. Left knee jack absent. Ankle jack absent. And touch was normal in the upper limb, but impaired for the toes. He could not say that. There he is able to tell. Pain sensation is normal in the upper limb. No difference between the little finger and the thumb. It is decreased on the feet, more on the proximal part. He will tell you when the pain is more. It is normal there in the mid thigh. There is a difference between the middle leg and thigh. He said decrease on the leg, the left leg. It's same middle leg and thigh normal. Decrease with the vertical calf. That's normal. Vibration normal, the upper limb. Normal the angle, but absent of the toes. No. No. Little normal. No. GPS sensation normal in the right upper limb. But made consistent mistake in the left little. Her each leg again with each normal. Normal.
പിഴ താഴോട്ട് പിഴ താഴോട്ട് പിഴ താഴോട്ട്
Made mistake. Twice he made mistake in the left little finger.
പിഴ
Lower limb totally not able to feel.
പെയിൻ ഉണ്ടെങ്കിൽ പറയണം ഇല്ലല്ലോ
SLR negative bilaterally. This is how he walked. Rhombus was. So, motor upper limb, tone normal, power all normal. Tone normal, power hip flexion, hip abduction, appear normal. Right hip was mildly weak compared to the left hip extension. I mean, hip extension weak on the right side, mildly, left normal. Knee extension normal. Dorsiflexion normal bilaterally, but EHL was weak bilaterally, more on the right. Plantar flexion almost normal in bedside examination. Mild weakness on the right side. Upper limb biceps supinated normal, triceps absent on the right side. Sluggish on the left. Finger flexion absent bilaterally. Knee jack, right knee jack just irresistible. Left knee jack absent. Both angle jack absent. Abdominal plus absent. And as mute bilaterally. Sensation touch impaired over the distal part of the both feet. Pain decreased over the medial and lateral aspect of the leg, over the dorsum and plantar surface on the right side. Decreased over the lateral aspect of the leg or the dorsum and plantar surface on the left side. I will show the diagram later on. Rest of the area is normal. Vibration normal in the upper limb, impaired over the toes bilaterally. JP's upper limbs impaired over the little finger on the left side, left little finger. All other areas normal. Lower limb impaired over the both toes. So this is the area of pain loss he had over the leg on medial as well as lateral leg, dorsum and plantar surface. On the left side, over the dorsum, plantar surface, and the lateral aspect of the leg, not present on the medial aspect of the leg. Touch and vibration loss was in the distal symmetrical fashion on the both feet. Joint presence both feet in the lower limb as well as left little finger. Rhombus was positive, gait walks with a wide base. You want any clarification of the findings? I can show once again.
Sir, what was the total duration of the disease?
Total duration is two months.
Sir, it looks like it is a sensory predominant disease affecting asymmetrically the upper limbs first, followed by the lower limbs. In examination, there is a patchy sensory loss over bilateral lower limbs with some suggestion of large fiber involvement in the upper limbs and lower limbs as well. Although the duration of the disease is 2 months, it is subacutely progressive. So, sir, a sensory variant of an atypical CIDP like MATSUM should be considered first, although other possibilities should be excluded also, sir.
A very good thought. That's a very good way of thinking. Exactly correct. Any other thing you would like to keep in mind?
Ganglionopathy also.
Okay,
So
ganglionopathy, but it's got a weakness or the right infection. So, okay, mild weakness can go with ganglionopathy also.
sir, how was the toe walking, sir? And the heel walking, sir?
On the bedside examination, they were normal. That I will show you later on.
Because he's bending his knee and walking, sir.
Okay, very good.
And
Okay, so what will you like to consider?
The subtle motor weakness should also be excluded, whether he is having some subtle plantar flexion or a dorsiflexion weakness, which would suggest
so
more of a CA.
Okay, more of CADP like presentation.
Yes,
Correct?
sir. Yes, sir. Yes, sir.
Right.
so can be mononeuritis multiplex also.
Yeah, also, see, essentially, MATSM is nothing but a mononeuritis multiplex. Only thing is there is a demyelinating type of mononeurous multiplex. That is my answer. Essentially, what it is multiple nerves are affected.
Sir, was there any peripheral nerve thickening, sir?
No nerve thickening. In fact, I did not look for it. Subsequently, I checked for nerve thickening. Okay. So CAD, these are things you kept in mind. Okay. What test you do now? NCS study, correct?
NCS, yes.
This NCS study. Sorry. CMAP is decrease the common and the left tibial. Upper limb normal, except for the mild distal simple contact the median nerve. Snaps normal.
Lesion should be proximal to the ganglion, sir. Ganglion neuropathy, because snaps are normal.
Okay. In that case, that part agreed, but he has also got weakness, no?
Yes,
So you have to consider CASMB like thing.
yes, sir. CISMP.
Okay.
But there is no
Okay.
gross ataxia, although the Romberg's was positive. The patient was walking with a cautious gait. But in case of ganglionopathy or CISP or CISMP, we should expect more sensory ataxia than this. The patient should fall even on standing.
Okay. Okay, what else you want now? FEV is also normal.
Sir, we
yes.
can do an SSEP
Okay, SSCP as well as
Chrono dispersion and other things was
as well as
right,
imaging of
right,
the roots.
right. Yeah, that can be done. Waveforms are normal, not much of a dispersed. FA, see, always FA is a problem. You will not get FA many times, but whatever FA we could, there was no definite prolongation. Some persistent decrease in some nerves, but most of the times this is absent because EMAP is not obtained in that left and right peroneal. Okay, this is the FA. Now, what do you want now?
Sir, ideally we should do both imaging of the nerve roots in the coronal position, and also we can do an SSEP, whichever we could.
Okay. Anything else?
Test studies, sir.
Yes,
Then
CSF
product-
can also be done.
Okay, CS also can
MRI,
be done.
MRI.
Okay, MRI where? LS
Lumbar
fine.
root clearance.
For the thickening of the roots or with
Yes,
contrast
sir.
study?
Contrast to be, sir. Contrast to be. Thickening the
Oh,
roots. Root and
okay. Okay. See, when I present such cases, no, always I hit some key findings. Only show it later. Because I the diagnosis obvious initially, but I want to make it interesting how people. This is how he presented, exactly why he presented, what he stated exactly same as presented. Only thing the examination finding, which I thought obtained only later on, not obtained later on, I looked for only later on after seeing his gait. Somebody has picked up that finding, but the interpretation was not exactly correct. I'll tell you. Now, what is again is the peripheral CAD?
The jerk DTRs were what were the DTRs? Sir? It's normal.
They are both lower limb absent except one sluggish knee jerk. Both triceps were absent.
The common coronal nerve pulse is not there, no, sir.
Those were no, EHL was weak.
EHL weak is not weak. But the
Yeah.
tibialis anterior is not weak, no, weak.
No,
Peripheral-
weak, not weak.
Like patchy, sir.
Yeah, it can
How
be
can-
patchy.
How can we say that, sir? It's the most common nerve which is affected in peripheral neuropathy. Motor nerve.
Yes, perfect. So what will you consider? I'll show you. Now see the gate once again very carefully. One of you have picked up that finding very correctly.
Plantar flexus, sir. Plantar.
Yeah, correct.
That's
Knee
why
goes
he's flexing his knee to compensate.
exactly. That is the finding we should always keep in mind. If we find that thing, it is unlikely for a peripheral neuropathy. Plantar flexes are more affected than the dorsiflexes. Examination express is normal. If you get plantar flexion affection, either it's a radiculopathy, very early tibial neuropathy, or a myopathy. Two things: radiculopathy, anterior versus myopathy. This is we can straight away come to that point. So it is the gait which gives the clue. So what did you notice? Is goes in deflection walking. What else will you do now? First to walk on heel and toes. Let us see. You could stand on heel, walk little bit without much falling. Let us see, ask him to walk on toes. He cannot even stand on toes. He goes in a knee buckle. See, this is how it happens in severe plantar flexor weakness. Because he cannot lift up his ankle at all, and knee goes into flexion. This is a typical finding of plantar flexion weakness, especially the soleus weakness. Okay, so unattended to walk on toes, he goes into flexion. Severe plantar flexion weakness, more affection in tibial nerves, or bilateral spondylocolopathy. There are two possibilities. Okay, he has got some numbers in the upper limb. So you can say CDP affecting more of tibial nerves. Agreed. But tibial nerve is more affected than convex or bilateral radiculopathy. So what would you like to do now?
MG.
EMG before
Sir,
EMG.
MRI of
MRI before that. Clinically, all clinical
S1,
medicine.
S1 reflexor.
Other
Sir, we
muscles
should
supply.
check for the
Yes,
hip
Reflexor.
abduction and the extension.
exactly. That is a word. See, H can be absent anywhere. He's got to have tibial nerve is affected or S1 root is affected. Both can put his H absent. So that cannot go into differentiate the two. So what you differentiate the two is this thing. One
Hip
back, hip abduction and hip extension. See the hip abduction now. See, it's got a sagging of the hip on standing on the right side, hip sags on the left side. I'll show you once again. See, hip is sagging on the left. That means right hip abductor is weak. Then examine the patient, the lateral. Again, the one which you hardly do is that we never examine the patient in the lateral prone position as well as in the extension when hip and the prone position. See, at the bedside, I got near normal hip abduction power. See his power now. On the left side, I can easily overcome. On the right side, he cannot even keep it against gravity. It sags down. See that one. So, hip on prone position, hip extension also weak bilaterally. More weak on the right. So both hip extension, hip abduction, plantar flexion weak. And with the normal count, we have got dorsiflexion. So it cannot be a peripheral neuropathy at all. So it's a cardiac annihilation. Right? L5 to S1 and left S1. No, that does not end here. What is causing the numbness of his left hand and absent triceps reflex? And numbness was his complaint. And impaired joint sensitivity.
Sir, it can be an unrelated cervical disc PIDT.
Correct. That's the most same. I told you before now, the earliest finding in cord compression in the upper limb is the involvement of the joints and little finger. This I have told me many times before. So that may be the initial beginning of a exercise compression. So most likely you have got a disc lowered or maybe disc balls. But the cervical disc is not that much symptomatic. The disability is because mainly of the lower limb of the disc affecting the lower limb. This already has Swami has said. Then why cervical myelopathy start manifesting the lower limb? Because it's already got element finding there, radicalopathy lower down. So in pyramidal lesion, if the dot is there, it will be masked. Okay. Why pyramidal lesion we suspect? We have no evidence of pyramidal involvement, but the post-collar involvement may be there because the joint senses have to be little bit. That means myelopathy has to be there. Or it should be a C8 radiculopathy. That we can explain C7, there C8 radical. But his abdominal reflexes are absent. So probably he has got a mild myelopathy above, but a significant radiculopathy below. So what investigation will you order? MRI LS spine and cervical spine. Whenever you suspect a disc prolapse in cervical spine, kindly do both inflection and extension. You may find small disc, which may think is not causing symptom. Many a time, many surgeries are not symptomatic at all. But if you've got some findings of associated myelopathy, and you find a small disc which you think that cannot explain the myelopathy, kindly do flexion extension. Then you will pick up the compression. Now this is the MRI of the LS spine. Anything abnormal? Mild disc, no? L4, L5, L3, L4.
Sir, axial sections.
I'll come to that. Come to that. That is a T1. Roots are okay. The chordae can apart come. That is T1. Now go to the axial. This is a T2 axial. There is a stenosis on the left side here. L4, L5 level. This can be seen. Stenosis at that level. Next level, L4, L5. Okay, not much of a stenosis, but there is stenosis. So contrast. Now contrast enhancement of lesion. Plexus. Normal. So what will you do now? Surgery?
Lower thoracic flex.
Lower thoracic spinal cord.
Yes, sir.
Why?
Sir, dorsal cord
Sir.
should be screened also.
Dorsal. But he has got L-face and radiculopathy, no?
Sir, proximal lesions in the cord can cause that conus ischemia of the lower limbs. So,
You mean it's the epiconus region?
yeah,
Right?
yes, sir. Yeah,
That
yes.
came in that. Anyway, I'll show that thing. Anyway, that part have been cut off, I think. Anyway, I'll show the picture once again. Dorsal cord column, I'll show you later. Now, again, another point. You may get an apparent normal MRI unless you do the T2 space. Now, see the T2 space. See the degree of compression of the spinal cord, or the spinal roots. This is our spinal cord, you can see above. See this one. See this. Hardly ever you can make out any roots above and below, both at L3, L4, L4, L5 level. See that one and that one. Almost totally compressing the roots.
Sir, but the compression is predominantly on the left side and the patient is having bilateral symptoms.
Actually, he has got compression on the left side. Definitely bilateral symptoms are this. In fact, having canal stenosis, where the ligament definitely have a compression as well as with the disc. It is the disc alone is causing a severe canal stenosis at that level.
Okay.
So,
Sir, what about the cervical spine, sir? Was there any disc in the cervical spine?
yeah, very well. So initially MRI was done, less fine. Then I wanted a cervical spine to be done. This is the same thing. I was asking. So this is cervical spine, which did not show any significant compression, mild compression. And this is the dorsal spine screening was also done. That is normal. Which in fact, it was in the previous picture also, it was there. Now, what do you want? Flexion extension. But unfortunately, what happened was that I phoned up the technician to do that. Somehow or other he did not do that. He said he forgot to do that. But subsequently, I did not press on it because anyway, the cervical part is not symptomatic. What is requiring is surgery for the lower part. So I thought that the cervical spine flexion later on. That's only where I can make interest. Yes.
You had symptoms of neurogenic claudication.
That is the funniest part. He never complained of neuroclaudication. He complained of, in a way it is there. His pain in the lower limb is more on standing and walking. That is my first slide. I'll show you. But first, see, this is how he presented with the numbness of the hand, numbness of the feet. See? Paresthesia, this is how exactly presented. And aching pain and cramps, which is more while walking. But there is no radiation down the back. Sometimes neuronic claudication pain, they may not give a pain rating on the back, only they combine the pain in the calf. But the clue is that the pain more standing and walking decreased by sitting. That is the clue. Besides, you need not necessarily radiate from the lower back downward.
Sir, in the NCS of the upper limb, there was slight prolongation of the median latencies, but the
Right.
snaps were normal.
Yeah.
Snap
No,
median snaps.
maybe some mild carpal tunnel symptom might have been there. Okay, the main thing about the cases too, always examine the patient, the standing in a healed position and lateral decubitus position and in the prone position. When you examine the low power in the position, he is trying his maximum to bring it again. It's a very cooperative patient. That is why I could not make out the mild weakness in the lying down position. In the examination, also in the initial examination, there was one clue. I told he had right hip extension was weak. All of the muscles said normal. AHL was weak, but right hip extension was weak. I told him the very beginning. That was the honest. That was there in this patient. The mild weakness on the right side. Okay, always make it a point to walk like that. And if the knee goes into flexion while walking, always think that it is not a metal neuropathy. Okay, shall we go to the next? Any questions before we go to the next case?
So, did the patient undergone surgery?
Yes. Yes, he is posted for surgery. He was immediately thought to require surgery at the earliest. Okay.
Sir, just one thing. In neurogenic claudication, the pain is usually more in the thigh region than that of the calf. Calf is usually a vascular phenomenon.
No, not like that. It can be said maybe in the calf, maybe in the back of the thigh, maybe radiating down. But that is where the problem differentiating between vascular claudication and neuronal claudication come, because they mainly complain of pain in the calf. That is where the problem comes. They're always asked these questions. When the pain disappears on sitting or not, or disappears on standing. If it disappears on standing, it is vascular. If it does not disappear on standing, it is neurogenic.
They can cycle very quickly. Bicycle, they can run with the bicycle.
Yeah,
But
exactly. Exactly. Because when they bend, it becomes magnetized. Shall I go to the next case?
Yes, sir.
Yeah, please. Any questions, please ask. Okay.
Sir,
Now-
1 minute, sir.
Yeah, please.
Sir, that little finger joint position sense was impaired, but there was not significant myelopathy. But in these kind of situations, or in every case, we need to do this cervical spine MRI inflection and extension.
Yeah, I'll tell you, there must be some explanation for the absent joint cells in the little finger. It may be in the peripheral neuropathy, it may be a C8 radiculopathy, or it may be a myelopathy. But under the context, we have got a dysplasia in the lumbar region. So somebody coming with bilaterally absent triceps reflex and numbness here and absent abdominal reflex, the possibility of early cervical myelopathy. That is why you have to strongly consider a flex extension feeding. Suppose they have only numbness alone without any other things. Obviously, you have to exclude other possibility like ulnar nerve involvement, C8 radiculopathy. But here the contraction was normal. There is no sensory finding in the snap abnormality in the ulnar nerve. But that does not exclude a C8 radiculopathy. So here it could be C8 radiculopathy or a early myelopathy.
Yes, sir. Thank you.
Okay. So you have to go rule out one by one. I'm not telling that anyone with numbness you should discuss cervical myelopathy. Not like that. You got some other finding pointed to that.
Okay, sir.
Okay. No. He was an old case. In fact, this patient may be an old patient who has been treating for the last 20 years. He was an old 15 years. He was an old case generalized myasthenia under remission. He had underwent post-thymectomy. Now on treatment happened for the last 15 years. In fact, in between, he came with symptoms as to neuroinflammation about 4 years back. It was not much symptomatic, so put him only on pregabalin. And he did not come for follow-up since he is very comfortable with that. So he came. But he came now for a complaint for the last 3 weeks. He noticed severe pain in both the legs, mainly on standing and walking. Moreover, he said that he was very much apprehensive, breathless, restless of the same duration. Wife was telling sir, the whole night he was walking about, feeling breathless and anxious, irritable. And these complaints are more while lying, and he tended to get up from the bed and walk about at night because of his pain as well as his restlessness. And also telling me he's got palpitation, apprehension. Examination was normal, except for a finding in the calves and thigh. This is the finding in the calf. Mainly in the right calf, but also present in the left calf. It is also present in the thigh to a much less degree. The vastus medialis. They can make out that on the left side. It is more when he flexes the knee, it becomes more prominent. It becomes more prominent when the muscle is put into contraction. Then come to this the trunk and back, very occasional contraction, but no other obvious, not like what he caught in the leg. Occasional, not present in the back. So what was abnormality seen?
Neuromyotonia.
Myokymia. It's not like myokymia. So
It looks like a continuous muscle fiber activity.
exactly, Isaac syndrome, something like that. Myokymia. So what question will you ask now? In India or in I don't know, but North India, in southern India.
Naturopathy.
Yeah,
Ingestion of this
It's a toxin.
Indigenous
More-
drug.
indigenous. And
herbals.
most common is Siddha medicine. Siddha, which contains mercury. I got 3 patients. One patient Siddha medicine for uterine fibroid, another for his what do you call as an aphrodisiac, and all the are this kind of circulation. But so history can take 10 always Siddha medicine. There was no history. He denied vehemently, no history.
You
Sir,
meant to-
what was the dose of pyridostigmine that he was on?
That I do not know because that he has been receiving for many 15 years. I think he was not on pyridostigmine. I think he was only on azathioprine. Was stable.
So autoimmune antibody sensor.
Which antibody?
So thymoma may also be associated with Casper2. So
Casper
we have to send for
Caspar
Casper2 as
sir.
well.
Okay, very good.
Caspar.
Yeah. NCS was done, which is normal. I did EMG from the to confirm that is a myoclonic discharges. This is the type of group discharges. Not the classical soldier marching soldier pattern. It's not that frequent, but there's a group discharge seen myoclonic. With the needle moving along with that. Okay, I did from the thigh also. Thigh is much less occasionally. That's a microdisc. Otherwise, motor action was normal. Because not innovation changes. So, Casper2 antibody. In fact, both Casper2 as well as LGA1 was also positive, but strong polypositive was Casper2. So, what will you do now?
Sir, we have to image for the CBCT for the recurrence of the thymoma or some PET scan because Casper2 is generally paraneoplastic.
Yeah.
Some
But
irritability and all, no, sir? Irritability or something. So,
irritability of?
no, he had some irritability, behavioral symptoms.
Yeah, that's all well described. The Morvan syndrome.
Yeah, Morvan.
Morvan. In Morvan syndrome is also now, most of the Morvan syndromes are now Casper2. They have got this kind of autonomic disturbances, anxiety, apprehension, insomnia. All these can occur with sleep related abnormal behavior, all can occur with Casper2.
MRI brain scan.
No, I did not do any of that. I did not do any of that test. Just sent for Casper2. Since there is no medication responsible for that. Came as positive, put the patient on IVAG. It's not IVAG, IV methylprednisolone. Pardon?
IV middle is enough, sir.
IV methylprednisolone.
Okay.
Initially, till the results came, I put him on pregabalin with no improvement of the pain.
PET scan is it needed, sir?
Pardon?
PET is it needed?
If it is a Casper2 is not a common antibody as a paraneoplastic, but you can do in that respect, you can do the PET scan. But this picture was very much like the Casper2 antibody mediated thing. And curiously, most of the Siddha medicines they take, those neuromyotonias coming after Siddha medicine have also they developed Casper2 antibody positive. So this can trigger this antibody production.
One thing, sir. Shall I, sir?
Yeah, please. Parveshare parnyo. Please.
If both LJ1 and Casper is positive, chance of a thymic lesion is 30 to 40%. There is a study.
Yeah, that in fact it was already been post-thymectomy patient.
It can recur,
Uh,
no, sir? Thymoma
recurrent.
We
recur.
had recurrence. We had for recurrence.
If it is LJ1 alone, chance is less than 2%. If both are positive, chance is around 30%.
Yeah, that we had to look for. I asked him to come for a CT just later.
Another
In the
thing,
meantime, I put him in treatment because I was severe pain.
another thing is like, no, there may be a limbic encephalitis associated, no? So in more vans, we could have done
No,
an MRI brain.
yeah, no, in a MRI, see, otherwise he's okay. He's except for these anxiety things, apprehension, he has no cognitive abnormality, no headache, no seizure, nothing. CT just should be done roller thymo. That's it. Okay, shall we stop or go for one more short case?
Sir, one more.
Sir, if you are having difficulty in speaking, sir, you are having some sore throat, so we might stop today because you are having difficulty in talking today, sir.
This is your case, only some a short case. I'll
Okay,
finish the
sir.
short.
If you have no problem, we will be very happy, sir. Thank you so much.
Only 5 minutes only.
Yes,
The
sir.
case was acute onset desenescence diplopia.
আচ্ছা আমার আঙুলটা যেদিকে যাবে সেদিকে তাকা, এইদিকে তাকা, আবার এদিকে তাকা, নিচে তাকা, এবার নিচে, ওপরে। আচ্ছা ঠিক আছে। দাঁতটা দেখা তো বড় করে, দাঁত দেখা, জিভটা বার কর, বড় করে বার কর, মা কালীর মতন বার কর।
I'll show the video once again. Here toes is to the right eye.
আচ্ছা আমার আঙুলটা যেদিকে যাবে সেদিকে তাকা,
Protection of the right
এইদিকে
eye.
তাকা, আবার এদিকে তাকা, নিচে তাকা, এবার নিচে, ওপরে। আচ্ছা ঠিক আছে। দাঁতটা দেখা তো বড় করে, দাঁত দেখা, জিভটা বার কর, বড় করে বার কর, মা কালীর মতন বার কর।
Okay, what is the diagnosis?
Pupil, sir.
What is about the pupil, sir? It is reacting or
No.
not?
Normal.
Looks like right third now, sir.
Yeah, right there.
Acute onset, sir.
Acute onset.
DTR.
Like this only fine short case.
Sir, it's not following a nerve pattern, sir.
Yeah, so you tell me the possibilities. It is not pure third, no? What else?
Right side of midbrain, she's having difficulty in vertical eye movements also.
Yes.
Both upward and downward. Both are.
Yes. So that
Adduction
means,
is affected.
okay, so vertical gaze palsy
And
plus right third
It
nerve
seems
palsy.
That are
facial is also affected, sir. Facial is also affected.
Facial is not affected. I don't know.
No,
But anyway,
he's able to close.
Yeah. So it's a right third nerve plus vertical gaze palsy. Can it be a vertical gaze palsy with right eye and no?
Yeah, right eye, no. With the
Those-
But
vertical.
those is there, no, right side.
Bilateral, no, sir.
Eh?
Bilateral
Right
down gaze is okay, sir, but bilateral up gaze.
Element
Both are
also
affected.
there.
So
Eliminate
if
that.
now my question is, both upward and downward gaze indicate what? There is a bilateral lesion of the RIMLF. Yeah.
And sir, when she's turning the head, it is not correctable, no? The palsy is
Yeah, it's not correctable. So in INO, do you think it is be correctable? INO also it will not be correctable because this is the pathway beyond our element, beyond the abducent nucleus. So in INO, wherever the site of lesion is, it also will not be corrected by oculocephalic reflex. Only it is proximal to the abducent nucleus lesion. It will be correctable. Because the VR pathway also getting connected to the abducent nucleus. Okay. What is the point against MLF in this patient? One which could I look for convergence, but convergence was not done here. If convergence was intact, that means it was an MLF lesion and not medial rectus. Here, what is the other clue? So you can't be ptosis. Ptosis, correct. So ptosis cannot occur with MLF. Okay, so that means it's so as you said correctly, midbrain lesion. It could bilateral and see involvement of the middle thalamus bilaterally and midbrain. So which artery is affected?
Arteriopercular.
Arteriopercular.
This is the classical site of middle thalamic involvement, arteriopercular. See that. That is lesion for our present pain symptom. But in the previous case, you said thymoma, but I thought that when the thymic recurrence occurs, usually the myasthenia should give worsen. Here the myasthenia was not worsened at all 15 years.
Yes,
that
sir.
That's not point. Usually that get worsened first. Okay, any questions in this case?
Yes, sir. One doubt. Why the bilateral ptosis is not there? Only right is it because?
No, it is not
in the nucleus. It was not in the nucleus.
Exactly. See, bilateral ptosis occur only in the nuclear lesions. In the fascicular lesion, beyond that, it's only unilateral ptosis. Okay. Any more questions?
Thank you, sir. You take rest, sir. Thank you very much, sir.
Thank you.
Thank you, sir.
Good night.
Thank you very much for taking this class with your sickness, sir. Thank you so much. We are so very grateful to you, sir. Thank you,
Sir,
sir.
advance
Thank you,
happy
sir.
birthday, sir. Happy birthday, sir.
Happy birthday, sir. Happy birthday. Sir, many happy returns of the day.
Happy birthday, sir. Happy birthday, sir.
Happy
Thank
birthday,
you.
sir.
Happy birthday, sir. Good night, sir.
Advance happy birthday wishes, sir.
Thank you.
Thank you, sir. Thank you. Thank you.